You're all set? All right. So hello everyone. Thank you for coming out tonight. My name is Neha and I am a junior molecular biology and global health major, and I'm also the student development advocacy director in student government. I'd like to start off by thanking both of you for being part of the Justice Now initiative, and I would also like to thank everyone from the Yukon community that's watching tonight. We want to give a shout out to the Student Development Committee for all of their hard work in pulling this series together. So the Justice Now series aims to bring activists and prominent advocates of the Black community to Yukon in an effort to bring truth to power. Our guests tonight are Dr. Regina Benjamin and Dr. Jerome Adams, both of whom have served as U.S. Surgeon General. So thank you both for joining us. So just to start off, could you tell us a little bit about yourselves and the path that you took to becoming the U.S. Surgeon General?
Well,
Dr.
hello, Dr. Benjamin. Do you want to start, please?
I'll let you, since you're the most recent.
Okay. Well, as Dr. Benjamin states, I was the Surgeon General under the last administration, but my pathway started far from there. I actually grew up in rural Southern Maryland on an old tobacco farm, ironically enough, given that I was ultimately the Surgeon General, who was most, the position known for being on the side of the cigarette boxes. I grew up as someone who was extremely sick, to be honest. I had pretty severe asthma and was in and out of the hospital, and I very much remember the challenges that we faced being in a rural area, accessing healthcare. I took 3 helicopter rides in my life. 2 of them were as Surgeon General. One of them was as a 8-year-old, where I had to be medevaced to Washington Hospital Center because I was in status asthmaticus, and they didn't have the medicines, the resources, the expertise to be able to care for me in my rural community. And if I hadn't been medevaced, then I wouldn't be here before you today. Unfortunately, we know that African American boys, in particular, have the highest death rates from asthma, and I almost was one of those statistics. But grew up in a family of 5. Family didn't have a lot of money. We relied on government assistance programs to put food on the table. And I often tell people that I actually never dreamed of being a doctor growing up, even though I had straight A's. And the reason I didn't dream of being a doctor is because despite being in the hospital all the time, I'd never seen a Black doctor until I got to college, except on the Cosby Show, which you all may or may not remember. And so, as a saying, you have to see it to be it, and I never saw it. And so, it's an important part of my story that I like to share because uh, many people, and I was at UConn a few years ago when I was Surgeon General, you asked, and many of you all ask, why would you serve under such an administration? And the answer I often give to people is, if given the opportunity and knowing my background, how could I not? How could I turn that down? Because I know there are little Black boys and people of color and people from rural communities and people who have asthma who didn't really associate me with a particular person, but saw me on TV in the White House, and maybe it inspired them to believe that they could too. So I'll finish really quickly because you don't want to hear me talking about my story the whole time. But I went to University of Maryland undergrad on a full scholarship, so was very grateful for that opportunity, and majored in engineering. And during that time, ran into a couple of people. The first Black doctor I ever met was Dr. Ben Carson, because he was there in Maryland, and decided to go into medicine, and went out to Indiana to go to medical school again on a full scholarship. And then after that, went to UC Berkeley to get my master's in public health. Came back to Indiana because I met a girl there, and she was from Indiana, and practiced for a few years. And the governor asked me to be state health commissioner, so I ran the State Department of Health in Indiana for 3 or 4 years. And the governor then became the vice president, and my name got thrown into the hat to be Surgeon General of the United States. So that's a really short version of a very long story from rural Southern Maryland on a tobacco farm to the guy on the side of the cigarette box.
That's great. quite inspirational. Well, I'm not going to bore you with my resume. It's out there on the internet. You can Google it, and because I hear it all the time. It's kind of boring, but I live in Alabama. I've been here all my life. My family's been here on the Gulf Coast since the early 1800s, and we still live on the same homestead. And so I have a lot of stories I could tell you. But the way I got involved in in medicine, and well, I too had never seen a Black doctor till I went to college, but so I didn't know I could be one, but I didn't think I couldn't, so that wasn't an issue. I just wanted to go to college. But the way I got involved in medicine and in organized medicine, particularly when I was an intern, I attended the Medical Association of Georgia's annual meeting. And one of the intense issues that was being debated was that sexually transmitted diseases needed to be taught in medical school. Well, I stood up in a room with maybe 15, 20 people and told them I had never seen certain diseases except in a textbook, and I thought there was a need. The resolution passed, and the Georgia delegation forwarded that resolution to the American Medical Association. And the Georgia delegation took me to the AMA to speak to the same issue, and the resolution passed. And within 6 months, every medical school in this country was encouraged to include sexually transmitted diseases as part of their core curriculum. I learned that one person can make a difference, whether it's in medical policy or in medical practice. And I learned that I could make a difference in medical practice when the National Health Service Corps sent me to Biola Battery, Alabama. It's a pretty place, but it's a poor place. I found a community of working poor, too poor to afford medical care, but too rich to qualify for Medicaid. I liked the people, I liked the community, and I wanted to practice medicine there. But I quickly learned that practicing medicine wasn't just sewing up to shark bites. I had to deal with what I call the land shark, the regulators, the reviewers, the red tape dispensers, not realizing I would become one of those bureaucrats at some day. but but what I learned was that my patients had problems that the prescription pad alone couldn't take care of and couldn't solve, like adequate housing, especially after Katrina, education, employment opportunities, clean water, and and all of those things that we now consider social determinants of health. But in those days, I didn't know what they were. I just knew they needed to be improved, particularly bringing adult literacy programs to the community. And so when President Obama asked me to become Surgeon General, it was really with mixed feelings that I would leave my patients at that time of 23 years and go to Washington. And you have to understand, I had been the only doctor in the town for those 23 years and in solo practice. And however, I realized that by going, 300 million Americans would become my patients, and that I wanted to bring my patients' voices and others like them voices to those tables and be speak up for them and advocate for them and be in the room when we're making those decisions. And so that's why I went and how I got to be Surgeon General. I'm now back here in Alabama running a health policy research program because as Surgeon General, released the first ever national prevention strategy. And prevention has been the basis of everything that my whole career has been based on. And so we're still trying to address those, particularly around those social determinants of health. But I'll stop there. We can talk about all kind of stuff later.
Thank you both so much for sharing your stories. So we can get right into it. So the first question is, public health has been at the forefront of the news due to the COVID-19 pandemic over the past 2 years. Where do you both see the future of public health in the United States?
Well, I can start off, and I just want to start off by saying thank you, Dr. Benjamin. We've known each other for quite a while, and she has mentored me throughout some really tough times. One of the things that I think is important for folks to know is even though surgeons general serve under different presidents, we actually all are still in touch with all the living surgeons general. So Dr. David Satcher, Dr. Jocelyn Elders, the current Surgeon General, Dr. Murthy, he and I talked just last night because many of you may have heard, he tweeted about his daughter, his 4-year-old daughter being diagnosed with COVID. But every time I hear from them, even though I've known them, I learned something new, and I'm inspired by your story, Dr. Benjamin. So thank you for sharing that. Uh, Quickly to the question, and there's so much we could talk about. We could talk about that one question the whole time, but I'm only going to talk about three um, quick things that are of importance to me or that I noticed, and then I'll leave Dr. Benjamin to cover some other areas. Data, disparities, and authority. And so one of the challenges that we had during the pandemic was that we were literally trying to drive the car down the road without headlights in the middle of the night while looking in the rearview mirror. The data we were getting was incomplete. It was often months delayed, and public health, quite frankly, most of the time, the data that you're getting on a state or national level is 2 years in the rears. And so you're not skating to where the hockey puck is going, as Wayne Gretzky says. You're skating to where it was several hours ago. And so, one of the things we've seen improve throughout the pandemic is data collection. Most states now have a real-time dashboard or a near real-time dashboard with their COVID numbers. That was not the case in the beginning of the pandemic. I was sitting in the White House and we couldn't give the president a straight answer on how many COVID cases we had, where they were occurring, how many hospital beds were full, how many ICU beds we had. That's different now. It's better, and that better infrastructure is going to help public health moving forward as it translates into our ability to collect and share data on other diseases. Disparities. The pandemic has shown a horrific light on the impact that the COVID has had on communities of color, and in turn, it's forced people to open their eyes to the fact that people of color are suffering from all sorts of health disparities. And I hope that continues to provide some runway for us to address these issues moving forward. And we can go into that in the question and answer or moving forward. But suffice to say, there's been an increased focus on disparities that I think can only help moving forward. And then authority. And I hate to be negative here, but one of the things that scares the HE double hockey sticks out of me is that you go around the country and there are laws being debated and passed every day that are taking away public health authority from health officials because of the anger and the vitriol and the politicization of the pandemic. And it's going to have an impact on COVID, but it's going to have an impact the next time you have a tuberculosis outbreak in your community and your local public health official can't appropriately detain someone. It's going to happen, the next time there's a foodborne outbreak in your local restaurant and your local health official isn't able to do the things that they've previously been able to do to protect the public. All those things are going to suffer if we go overboard, and I really do think we're going overboard in many places with public health authorities. So data, disparities, public health authority, I think, are three areas that public health is evolving because of this pandemic. Some in good ways, some in not so good ways.
So I would just say, you ask, well, where do I see the future of public health? I'm really concerned about the future of public health. Jerome and I had the awesome privilege of leading the United States Public Health Service, which is under my command, it was 6,500 officers who are spread around the world to protect the public's health. That public health infrastructure is so vital to the health of America and of the world. And so that is being eroded. We in this country particularly, we take for granted that the water that we drink is going to be clean. It's not going to make us sick. We take for granted that our septic tanks and things are going to work. We take it for granted and we expect our food to be safe when we eat it. We expect the air that we breathe not to be contaminated. All of those things are because of public health. And I always look at public health like a interstate highway, that if everything's going smoothly, you take it for granted. Let one of those arteries be blocked and it blocks up everything. So what we're seeing now, and particularly what's concerning me, is that all these people, particularly these officers in the public health, scientists who have devoted their lives to protecting the public, are now being attacked on just because they're trying to keep you safe. And there's an attack on science itself, and there's this erosion. And so as we see all of this vitriol out there and politicizing public health is so dangerous to all of us. And this outbreak of COVID is just, you know, an example, but we could have Ebola, we could have anything, all these others, and that infrastructure would not be in place. So I think we need to have a concerted effort as a society to put an emphasis on keeping our public health infrastructure in place, and that we support it and make sure that um, our leaders and our elected officials do the same.
And one thing I would just add to that is that you all can have a role. You all can go to the state house. You all can call your local legislators. You can send a letter or go and talk to your, or ask to go and talk to your mayor. You can lean in right now and say, hey, we are worried about our future, and we think this is why you should protect and preserve public health authority. And even at the State House in Indiana, in downtown Indianapolis, we've seen students, undergraduate students from IU and Purdue, go and testify at the State House on bills where they're trying to take away public health authority from local officials. So please understand, you're hearing from two former surgeons general, and we're telling you we're scared about your future. And so I really want you all to think about that and to think about the ways that you can lean into protecting that public health infrastructure and authority moving forward.
Thank you. So the next question are what are the main barriers to healthcare access that both of you see, both in in your communities and also in the United States?
I've been going first for a while. Why don't you go first this time, Dr. Benjamin?
Yeah, I mean, this kind of comes right into my prevention stuff. I think one of the biggest barriers, and I always, this isn't new for me to say this, is education. I think a basic good education for our high school, K through 12 education, um, get more people involved and interested in going into college and to other places and being educated. Because um, it's hard to teach someone how to think if they are not part of the conversation. And the only way you can be a part of the conversation is have that basic understanding of education. So that's a big barrier to access to care. And the other part I see is having people take control of their health themselves and giving them the tools to do so. You know, we in public health always say, you know, health doesn't occur in the hospital alone. It occurs where we live, where we learn, where we work, where we play, where we pray. It's in everything that we do. But we can't expect people to be healthy if we don't give them the tools and the things to make it easy for them. You know, the healthy choices should be the easy choices and the affordable choices. If you can't afford to eat, you can't worry about how healthy it is. So we, particularly in government and in places where we're making policy, we have to make those remove some of those barriers. And that brings me to that the social determinants of health. And that in itself is, you know, I'm sure we can talk about those a little bit more, but education and making sure, and also I want to say about education is that our studies show that just by getting a high school diploma, your health outcomes and your life longevity is improved 5 times, just not by going to college, not by getting a better job, just by finishing high school.
So I'll jump in, and I just want to start off by seconding something that Dr. Benjamin talked about quite a bit, and that's the social determinants of health. But I want to give you a statistic to really cement it home. About 80% of your health is determined by things that happen outside the hospital and outside the clinic. Or put another way, only about 20% of your overall health is determined by your access to traditional health care. So the question you ask is, what are the barriers to health care access? What we should really be asking ourselves are, what are the barriers to health that exist in our communities? And they're the things Dr. Benjamin mentioned: transportation, access to fresh fruits and vegetables, a job that pays a living wage, paid time off to take care of your children if you're a mother or if you're a father who wants to be at home and to assist around the house. All those things matter in terms of your ability to be healthy. But I tend to think in threes. And number one, I'd say cost. We know that the number one reason for most bankruptcies in America is still medical bills. And so cost is still a major issue for people. We know that it's a reason why many people forego prevention and forego health services, uh, and ultimately end up, particularly in minority communities and in rural communities, showing up with chronic diseases sicker and later, and ultimately having higher mortality. In many cases, it's not that you're Black or that you're Hispanic that's causing you to die at a higher rate. It's the fact that you're showing up with stage 3 or stage 4 cancer instead of stage 1 or 2 because you're worried about the cost. So cost is a big issue, but also access. And access is different than cost. And this was a big um, issue, and it continues to be a big issue when we talk about healthcare coverage. Healthcare coverage is necessary but not sufficient, because in many communities, you can have a card, but there's still not a doctor who will see you. There's not a doctor in your community. As Dr. Benjamin talked about earlier, they could have all the coverage in the world, but if there's not a doctor in that community who will take that card, or who's even there to see them, that's an issue. And it's why we need to encourage more people and people from diverse backgrounds to go into medicine, to go into nursing, to go into pharmacy, to go into public health, and encourage them uh, to live and work in those communities that are most at need. And then the final barrier, because again, I like to think in threes, cost access is trust. We know that in many cases, um, poor people, people from different parts of the country and different regions, don't trust the healthcare system. So they might afford it. There might be a doctor there. They're still not going to go, or they're still not going to follow the instructions of that physician or health provider, because there's not that trust there for many historical reasons. For Hispanics and Latinos, it may be because of fear that they're going to be deported, or that their family is going to be negatively impacted from an immigration point of view. For African Americans, it may be the legacy of the Tuskegee experiments. And I got to tell you, one of the more powerful memories I have is walking every day to my office, the same office that Dr. Benjamin was in, uh, and it has these pictures on the wall. And these are the pictures of the past surgeons general. I was just the 20th surgeon general. And you look up there, and six of those surgeons general, six of those prior surgeons general, white men, oversaw the Tuskegee experiments, where they denied care to African Americans for syphilis for over 50 years, almost 70 plus years, because they wanted to see how syphilis played out in those individuals, lied to them and denied them care. And so you talk about trust when it comes to vaccines. We can't overcome 70 years of mistrust in 17 months of a vaccine being available. So cost, access, and trust, I think, are major barriers.
So can I pick up a little bit on that, since you brought up the Tuskegee thing? I just have to kind of talk about it a little bit. It was the United States Public Health Service and a public health service officer who conducted those experiments. But in Alabama is where they conducted them. The Medical Association of Alabama, they did it with the approval of the Board of Censors. I had the unique privilege of being the first woman and the first African American to serve on that board. And having served on that board, which was the same board that had allowed those experiments to happen, was significant, has special meaning for me. And for another reason, it has special meaning is that my stepmother's father was one of those gentlemen that, and all of her, she's 93 now, but while she was growing up, she had to get tested, and she was a part of the follow-up. So I lived with it, I grew up with it, and had the again another privilege of being on serving on a committee for the apology committee at Tuskegee when President Clinton made that apology. But when I was in office, we saw some of the same things starting to happen in it was is it Guatemala? It was the country, and President Obama and the Secretary of HHS made an apology there, and we basically said it will never happen again. And because of um, the ethics and the ethical foundations around science, what we've done with um, Nuremberg trials and all of the other things that have gone on, these things should not happen. People tend to bring it up a lot around vaccines. And this is what I'm getting this long conversation to tell you, is that the Tuskegee experiments, they knew that these gentlemen had a disease and withheld treatment. Today with COVID, we have a treatment and we're withholding it from ourselves. That is totally contradictory to what was done. We're doing the dirty work to ourselves, that we should be taking or participating in a treatment and a prevention with the vaccine of prevention that we know science tells us works. Anyway, I just had to throw all some of that stuff in there.
No, I'm so glad you did, because I didn't want to. I didn't want to push you into a place that you weren't comfortable going. But I know that you have, you know, more knowledge and history about that than anyone. And I'd ask you. I mean, you walk by those same pictures. Your picture's on that wall. My picture's on that wall. You know, I literally had internal debates myself about whether or not, as Surgeon General, we should take those pictures down.
No,
You
I
know,
don't have any problems with that.
I
I
mean,
think it's
but I just mean that
yeah.
when you walk by, did you
Well,
think about
I think
Tuskegee
when
and
I
the fact
walk
that
by
they
them,
perpetuated it?
when I walk by them, I said that it's a reason I'm here. There is a purpose for me being here,
Yep.
and never forget. So I want to see their pictures so that I don't forget and people behind me don't forget. So it's I don't want to erase the history. I want to learn from it and move on. I mean, so I want to make sure it never happens again. So,
I love that, because that's ultimately where I settled myself. I said, you know, um, I want to remember, and every day I walk by, you know, it just reinforced to me the importance of me being there and
yeah,
creating a new and different pathway moving forward. Thank you, Dr. Benjamin.
sure.
Thank you for sharing
Oh,
that.
I forgot what the question was. Sorry, Mia.
Um,
We were talking about barriers to healthcare
yeah,
access,
very so.
and I brought up trust.
Yeah. And
And
I
look
guess
what it
the other
turned
thing,
into.
yeah, the other thing I mentioned along those, and I think you covered them pretty well, but that your zip code should not be a better predictor of your health outcomes than your genetic code. We really have to take care of the inequities that we have in our healthcare care system, and that can't be done in healthcare alone. It has to be done around finance. It has to be done around the entire community has to take a role in it. And that's where it comes to dealing with those social determinants, dealing with that education, making sure you have a decent job that you can take care of your family, making sure that you have clean air to breathe and that your water is safe and all those things. Those all come to play um, to make us a healthier community. So,
Absolutely. So the next question goes in a little bit of a different direction. So the United States has been grappling with a number of crises beyond the pandemic, including the opioid crisis. So how has the pandemic affected the opioid crisis, and what's our next step? How do we deal with it?
well, I know that Jerome has a personal story to tell you about that. So but I want to get a little bit of thing off of my chest right now is that we have decided that everything now is a crisis.
Mhm.
And it is. And I'm not saying it's not. It is a crisis. But when we have a problem, you're going to say we have this crisis. Every time we have a problem, it's a crisis. We have been dealing with some of these so long that it's time for us to just take care of them. They should not rise to the level of a crisis. The opioid I'm not going to go into because Jerome, I know your story about it. So why don't you talk about it? So,
Oh, well, so I'll tell you my story really quickly, and then then Dr. Benjamin can give context. Uh, my own brother suffers from substance use disorder, and while I was standing in the White House, next to the leader of the free world. At these press conferences, my brother was in a prison cell 25 miles away due to crimes he committed to support his addiction. And it started with anxiety and depression that was both unrecognized and underappreciated and stigmatized to the point that he didn't feel like he could speak out and not addressed. We talk about the access issue. So there weren't doctors who were asking that he was seeing regularly who were asking him about his mental health, and he self-medicated, which a lot of people do, particularly in communities of color. And he self-medicated with alcohol and tobacco, which are disproportionately marketed in communities of color. Marijuana, which everyone now thinks is perfectly safe and acceptable. And we can talk about that during the Q&A if you all want to. But I put out an advisory about youth and pregnant marijuana use while I was Surgeon General. And then one day he went to a party and someone gave him a pill, and the pill was like a light switch went off. That's the way he describes it. And he rapidly went down the pathway of addiction. And the pill he got at a party is a pill that may have been overprescribed by me, because when I was in medical school, when I was in residency, I was taught that opioids were non-addictive, and that you were a bad doctor if you didn't prescribe opioids to your patient. We were told pain was the fifth vital sign. We actually received payment based on whether or not we hit these patient satisfaction scores, and the only clinical measure on the patient satisfaction scores was a question about whether or not the doctor did everything they could to control your pain. And so, in multiple ways, I've seen this opioid situation evolve. But as Dr. Benjamin said, addiction has been around for as long as humans have been around, and people self-medicate until we start to recognize whole health, that mental health is just as important as physical health. Until we destigmatize uh, mental health and anxiety and depression and mental illness, until we destigmatize that, we're going to continue to see the problems manifest. It's crack, and then it's opioids, and then it's meth, and it continues to go up and down like you're squeezing a balloon, but we aren't really dealing with the root issues. During the pandemic, we saw both stress from the pandemic and lack of access to services because of the pandemic cause opioid misuse to skyrocket, and opioid overdose deaths went up by 30% in the general population. They went up by 40% among the African American and Native American communities. And so, once again, you saw disparities play out against the backdrop of a national issue. But again, to close, as Dr. Benjamin said, uh, it is an acute increase, and some people will call it a crisis. But the fact is, it's been there for decades. It's been there for centuries in some way, shape, or form. And it's time for us to call it what it is, and to finally make sure we integrate mental health into physical health and our ideas of overall health and health care.
It is one of the crises. We have so many. I mean, it just everything is. It seems, and I think they're crises because we haven't taken care of them. We could have taken care of these things a long time ago. But mental health is a bigger issue than just the opioid crisis. And that's another place you see disparities. If you see a Black person that has an opioid addiction, they don't call it that. They call them a drug addict. Or the same thing we saw with George Floyd. He was using drugs. He was a drug user, but the drugs he was using were opioids. But he was never referred to as a victim of an opioid, you know, addiction. So we as a society have to kind of come to grips with that. But I want to get to another point around mental health and mental health parity. We we talk about mental health, and we talk about how we need to change things, but we're not willing to invest our time and resources into it. I just was a part of a bipartisan commission report on behavioral health and primary care. We have um, severely mentally ill, which certainly need to be treated, but we also have those functioning people with depression and anxiety and addiction, and those we see every day, and we don't have enough psychiatrists or mental health workers to deal with that. So we're proposing that we train our primary care doctors, give them the tools and some education as well as some resources to be able to handle some of these things in their offices. That'll decrease some of that stigmatism. I'm going to my family doctor or my internist. You don't have to know I'm going there for my mental health issues, but you can get all of those done, and having it in the same place can lead us a long ways. And so that's one of the proposals that's out there. We're trying to get people to understand how it's a part of our everyday lives.
Yeah, absolutely. I'm actually really glad that you both brought up mental health because it kind of brings us to our next question. So Dr. Benjamin, I know you said that you don't think that everything is referred to as a crisis, but many people have been saying that we are in a mental health crisis due to the pandemic. So, how do you balance conflicting priorities when you're designing mitigation strategies for COVID?
Um, you know, COVID is tough on everyone. I mean, it's the toughest part. Toughest part is watching almost a million people die and going to their funerals and particularly in the Native American community. It was just an article out last week about how many children have lost their primary caregiver to COVID. How many young kids don't have their parents anymore because of COVID deaths. There are so many of us who've been touched by just losing a loved one from something that was preventable. It was preventable. And so the mental issues around COVID are so many and it changes every day. At first, we were just afraid we were going to die. And then we got a vaccine. Now we're afraid, do I take it? Do I don't take it? Do I whatever? Can I wear a mask? Do I not have to wear a mask? And the uncertainty, the not knowing is so stressful. Then we watch all of this stuff on TV and we're angry and we don't know why we're tense and angry because we've watched all of this confusion. And at some point we need to find ways to take care of ourselves. And I'm on a board of a trust called the Well-Being Trust, and it's about your well-being. It's a foundation, nonprofit foundation, but we've also told people over the years, look out for yourself, take care for yourself. And I strongly believe that we need to do that. But some people have taken it so far that they've become selfish. And so at what point do you look to help yourself and take care of yourself, particularly your mental health, but you don't do it at the expense of others? And so we've got to find that balance that, I'm going to do what I want to do, regardless of what it means to you. And, I'm steering off now, I'm getting into other topics, but it is important that we take care of our mental health. I had this thing at Surgeon General. You have all these various campaigns. Mine was called Your Journey to Joy. I think you need it to be joyful, have fun, eat things that taste good. Healthy foods can taste good, exercise. And one of the things was to take a dance break in the middle of the day. You can be sitting at your chair and, just move, exercise, move, dance, or whatever, but something that brings you joy in the day.
So the question was, how do you balance multiple different crises or things going on? And I grew up, like I said, in Maryland, grew up on the Chesapeake Bay, and there's this phrase that we have called like where we say like crabs in a barrel. And if you've ever seen crabs in a barrel or a basket or a bucket, one gets to the top, and the other crabs literally grab onto its claw and pull it back down. And unfortunately, that's what we do with this crisis mode type of framing for diseases, as Dr. Benjamin puts it. We say, okay, now it's Ebola. Everyone drop everything else that they were doing and focus on Ebola. And then it's Zika. Everyone drop what they're doing and focus on Zika. Then it's COVID. Everyone drop what they're doing and focus on COVID. And so the way that I look at these issues and the way that I try to frame them to people is that we've got to stop putting on band-aids downstream. And we've got to figure out how we get upstream and deal with the root issues. And so what's interesting about all of these diseases is that they disproportionately impact the same communities over and over and over again. COVID, we actually didn't have a much higher infection rate for COVID than the rest of the developed world. What we had was a much higher death rate than the rest of the developed world because we had so much obesity and so much chronic disease as a burden in our country. So when people actually got infected, they were much more likely to end up in the hospital and die. So the real key to preventing deaths from COVID in the future, or whatever the next pandemic is going to be, is really investing in our communities so that we have complete streets so people can exercise, making sure we have access to affordable fresh fruits and vegetables so that people can make healthier choices about what they're eating, making sure we have mental health and wellness incorporated into our communities, into our schools, into our doctor's office visits, so that we have more resilience the next time something else flares up as a crisis and we know how to deal with it in a better and more productive way. The focus on the social determinants of health, the, um, the racial determinants of health, the personal determinants of health um, will really help us for whatever disease we're dealing with. So whenever I see a crisis, I try to say to people, okay, let's put on a tourniquet if we need to stop the bleeding, but let's figure out how we get upstream and actually do deal with the root issues, the definitive issues that are causing the problem in the first place. And as we come out of COVID, that's what I'm continuing to do. I'm saying, how can we build healthier communities? How can we use the funding and attention that's coming for COVID? And one of the things we were actually somewhat successful in doing was really loosening up the funding. So previously, when you had H1N1, there was a lot of funding that went to states just for H1N1. And the fact is, the funding got there in many cases long after the H1N1 no longer was a problem. And a whole bunch of health departments had gloves and masks and all sorts of money that they had to spend. And it said you could only spend this on H1N1, and that money went to waste. Those gloves sat in warehouses and rotted, and it was an inefficient use of funds. So, having seen this from a public health standpoint, as a public health official, I fought when I was Surgeon General to say this COVID funding, we can't have strings attached that say it's only for COVID. We've got to widen it to say that you can pay for the social determinants of health, that you can use it for other ancillary issues so that we can fix these larger problems moving forward. And that will lower cancer rates, it'll lower diabetes rates, it'll lower rates of asthma from people living in unsafe housing and lead contamination, and it will help us in many ways that go beyond just the latest crisis du jour.
So I want to just talk about balance a little bit, not specifically around COVID, but I'm always asking people to make a difference, and I want you guys to ask yourselves, where can you make a difference, and where can you know, play a role? And it's people look up to you. I mean, the college students, you may be the first person in your family who went to college, or the little kid down the street, maybe they're all looking up to you. So lead by example. But as you're doing that, you have to take care of yourself. And you've all heard the little thing about when you're on an airplane, put your own face mask on before attempting to help others. You've got to take care of yourself first. So make sure I always say, get your flu shot, make sure you're vaccinated, get exercise, and do the right things. But you've got to find balance. And I have a friend, Phil Later. He was ambassador. A lot of people know him, but he tells this story, and I always think about it when I think about balance. That we're all juggling a lot of balls in the air, and we're trying to keep those balls in the air doing so many different things. You have to decide at some point. There are some balls that are rubber, and there are some balls that are glass or precious crystal. You have to determine which one of your balls is rubber and you can drop it for a minute and it'll bounce back. Which ones, like your family or your loved one who may need you, is precious, precious crystal and you can't drop it. So you decide which one of your balls you can drop at this moment. And as you balance those balls, you will know which ones are precious crystal to you.
Thank you. I really like that metaphor. So since we are almost out of time,
One more thing. Just, I just thought, Dr. Sorry, Jerome, I keep got Dr. Adams talked about the crabs in the basket. I have crabs in my crab basket out on my pier right now, and so I eat crabs every day. But I'm an optimist, and so I think of it with those crabs as they're reaching up. Not that they're pulling each other down, but they're trying to go up with them, and they're giving them a lift. I like to think they're giving them a lift, but they're actually trying to push them up. And as we get successful, that we don't forget to reach back and pull others up with us, and that a good leader will do that. But a great leader won't stop there. They will push them out in front of them and let them know that they got their back, and they will make sure that they'll support them and they'll be there when they need them. And that's what we need, particularly in health careers. And because right now, less than 7% of physicians are minority, similar numbers for nurses, pharmacists, and yet over 30% of our population is. That 7% is the same percentage as during the Flexner Report of 1910. We really need to encourage minorities to go into health careers. If you see somebody or know someone, just give them a nudge. And even if they don't become a doctor or they become a Wall Street analyst or someone who is investing in healthcare, it's fine. But at least encourage them. And if you're, out there and you're one of those in pre-med or in science, stick with it. We really need you.
Thank you. So, this is our last question of the night. So, last fall, the University of Connecticut declared racism a public health crisis. So, why do you think that highlighting racism as a fundamental driver of health inequalities is important? And how do we move past that declaration into making better policies?
I'll go first. But I believe, as I said earlier, there are social determinants of health, there are personal determinants of health, and it's undeniable that there are racial determinants of health. And I think it was important for the University of Connecticut to do that. I think it's important for other places across the nation to acknowledge it. And I think the pandemic has given us a real opportunity. And so almost 1 million people have died as a direct result of COVID. Over 1 million people have died in terms of CDC excess deaths during the time of COVID. It's a tragedy by any measure. Uh, that said, I want you all to remember that the greatest health advances we've made in our country have often come during times of war or crisis. When you look at transfusion therapy after World War I, antibiotic usage after World War II, advances in trauma care after the Gulf War, the advances in telehealth during COVID. We went from 10,000 telehealth visits a week paid for by Medicare pre-COVID to 1 million per week at the peak of the pandemic. The delivery of healthcare will never be the same again because of COVID in many positive ways. When you look at warp speed and how we were able to develop vaccines, and now they're using that same technology to try to develop vaccines for HIV. Um, there are positives that can certainly come out of this, and one of the positives is the focus on disparities and the fact that people can no longer deny that individuals of color have disparate health outcomes. So then, what do we do about it? We've got to say, okay, how can we do the research that looks at not only why it's happening and uncover why it's happening, but also look at the interventions that help us mitigate it? Because that's really what it's about. It's not about pointing fingers and blaming. We need to help people understand that. It's about identifying a problem and coming up with issues to solve it, which is what we do in healthcare. We try to improve quality. We want to improve the quality of the care we provide, and we cannot do that if we don't acknowledge the disparities that exist and the root causes of many of those disparities. And we also have to distinguish between individual and institutional racism, acknowledging that you are part of a system that is racist and that you may even be perpetuating it doesn't mean that you yourself are a racist in the sense that we traditionally think that you're out there as a member of the KKK trying to harm people of color. And I say that a little bit tongue in cheek, but we've got to understand that's the concern people have is they think that when you talk about it, that it means that you're blaming, you're shaming, and that and that they're being called a racist. And make no mistake about it, there's some people out there that are, but I've been part of racist systems before. It's not that I'm inherently a racist, but I've got to acknowledge these systems are disproportionately harming certain populations, and that we need to take measures to correct it, because that's what you do as a good doctor.
Yeah, I'm not quite as academic, so you did a good job with that. But racism is real, and it's one of those things that has become such a negative connotation, and it is. But race is not necessarily negative, and so we have to embrace our differences and what we bring to the table, the flavors that we bring. Um, it would be a very boring world if we were all exactly the same. And it's like um, you, I, if someone says, I don't see race, I don't see color. Well, that's hurtful for me because I want you to see me as I am, and I'm very proud of my color. So that means you don't see me. So understand that it's not a negative; it's a positive, and so embrace it. I live down here on the Gulf Coast, and so one of our biggest or most popular dishes is gumbo. What would gumbo be like if it was all just one thing? You have to put all these different ingredients in, the various spices, the various flavors, and then let it simmer. And you come up with a wonderful dish. You wouldn't get that if everything was the same. And that's how our nation is. It's like we need to embrace who we are and make us better because of who we are.
Absolutely. So Dr. Benjamin, I know that you said that you wanted to share a poem. Would you like to share it?
Yeah, I wanted to say, I'm always asking you guys, everyone, to please try to make a difference. And in doing so, um, I wanted, because it's Black History Month, wanted to share with you a poem that was a favorite of Dr. Benjamin E. Mays. He was a educator at Morehouse College and part of the civil rights movement. And I learned about this poem from Dr. Satcher, one of our mentors, previous Surgeon General. But I hope that you'll make a difference. But the title of the poem is God Meant It, and it goes like this: I only have I have only just a minute, only 60 seconds in it, forced upon me, can't refuse it, didn't seek it, didn't choose it, but it's up to me to use it. I must suffer if I lose it, give account if I abuse it. Just a tiny little minute, yet eternity is in it. I hope each of you will take your God minute and make a difference.
Thank you so much for both of you for your incredibly enlightening answers. This was really amazing to moderate, and it was such an honor to speak with you and to learn about both of your experiences. So, are there any last thoughts that either of you would like to share with the Yukon community tonight?
I'd like to say to you that I'm so proud of you and the work that you're doing and putting on this series, and all of those who are out here listening and participating in them. We have such expectations of the great things you guys are going to be doing.
And I just want to say thank you for having us on to speak to you tonight. One of the things that Dr. Benjamin and I have talked about before is how much we really enjoy, particularly talking to students, because we're just one person, each of us. But uh, if we can impart just a little bit of hope, a little bit of inspiration, a little bit of motivation to you all, then our impact will be multiplied exponentially, and it will go on far beyond anything we could have ever dreamed. So thank you for having us. Continue to work hard, continue to believe in yourself, continue to collect mentors and sponsors, because we didn't get a chance to talk about that. But both of us have had many mentors and sponsors that have opened the door for us. And also, as Dr. Benjamin said, uh, be willing to be a mentor and a sponsor for those who come behind you, because again, you may not believe this, but there are people in your life right now who are looking up to you right now. There are people in your life right now who never dreamed they would be where you are. So remember that every time you look in the mirror, that you've got so far to go, but you've also come so far, and you can be a mentor, can be a source of inspiration to other folks out there.
Absolutely. Thank you. So with that, on behalf of the Yukon community, thank you so much for taking the time to speak with us. And to all the students watching right now, thank you for joining us. And please make sure that you fill out the RSVP form that is on the webpage. Have a good night, everyone.
Bye-bye.
Thank you.